Good evening, everyone, and welcome to the first Imaging Working Group Journal Club for 2023. My name is Firas Al-Badareen, and I'm the head of the Imaging Working Group of Emirates Cardiac Society and a multimodality imager from Cleveland Clinic, Abu Dhabi. Today, we have a very interesting and exciting topic to discuss in the month of February. And we have a very exciting article that was recently published. And our speaker tonight is going to entertain us and share with us some unique insight about ischemia with no obstructive coronary artery disease, or known as INOCA, and recent insight from the ischemia trial. My co-moderator and presenter for the evening is Dr. Manu Agarwal, who's a close colleague and friend from Cleveland Clinic Abu Dhabi as well. Manu is a cardiologist at Cleveland Clinic Abu Dhabi who has multiple interests, including cardio-oncology, cardiac imaging, and pulmonary hypertension. He joined us from UCLA, where he trained for cardiology, and we are very excited to have him. So our flow for the night will be as follows. We'll start with a case presentation, and then Dr. Manu will provide or will share with us his analysis of the chosen article. We'll have some area where we discuss this article and share some remarks. We'll provide a follow-up on the case, and then we'll open it for discussion. Please feel free to put in your questions in the chat box, and we will do our best to answer and address these questions. So without further ado, the case presentation for today is a 70-year-old female who's not known to have coronary artery disease before. She was seen in the office for recurrent chest pain episodes that started about a month before the presentation. The pain is burning in nature without radiation and happens at rest and not necessarily with exertion. She's known to have hyperlipidemia, diabetes, and hypertension, and is a non-smoker. She had a normal resting ECG, and the physician at an outside hospital opted to work her up with a cardiac CT, which showed coronary calcification and some intermediate coronary stenosis, multiple territories of indeterminate or intermediate severity. At that point, the family and the referring physician opted for further management, and the patient was referred for cardiac catheterization. This is the patient's coronary angiogram, and as you can see, she has minor non-obstructive epicardial coronary disease seen in her LAD and circumflex, and the right coronary artery had similar findings. The patient was labeled with a non-cardiac chest pain and actually was dismissed from a cardiology clinic. Unfortunately, she continued to have symptoms and returned 3 years later with persistent symptoms, chest pain that radiates to the left arm. She, this time, was referred for a SPECT myocardial perfusion imaging study, which showed normal myocardial perfusion and normal systolic function. She was treated with bisoprolol for consideration of some small vessel disease, microvascular angina. That did not eliminate her symptoms, but only decreased their frequency. And after that, the patient was treated with nitro spray that also minimized the severity of her symptoms. There is more to this case, but I'm going to stop at this point and open it up and turn it over to Dr. Agarwal to tell us about this situation, where I hope I set the stage to show you the extent of the problem, patients, persistent symptoms, in the setting of non-obstructive coronary artery disease. Dr. Agrawal?
Thank you, Dr. Firas, for the kind introduction. Okay, so we'll jump right away to the presentation. So this article was recently published in JACC Cardiovascular Imaging, and it's basically focusing on INOCA. These are the insights from the Ischemia trial, which was the international study of comparative health effectiveness with medical and invasive approaches. I have a quick question. So there is a 55-year-old female who presents for typical chest pain evaluation. She has no known history of any hypertension, diabetes, smoking, or no prior CAD. She undergoes echocardiographic stress testing, and that shows moderate to severe ischemia involving the LAD territory. You send her for the cath, and the cath shows normal coronaries. The question I have for you is, and I just want you to hold this thought, was this stress test that was ordered for this patient was false positive? So the background for INOCA can primarily be defined as patient having myocardial ischemia with no obstructive coronary artery disease or normal coronaries. If you are defining no obstructive coronary artery disease, it's usually defined by less than 50% stenosis on a non-invasive anatomical imaging modality such as CT or on invasive coronary angiography. So why is INOCA clinically important? INOCA has been shown to be associated with major cardiovascular adverse events. Patients with INOCA more likely to have increased risk for major cardiovascular events when compared to patients with normal coronaries. As you can see in these graphs, the blue denoting normal coronaries and gray denoting obstructive CAD. The non-obstructive CAD lies right there in the middle, and it has increased risk when compared to the normal coronaries, but decreased risk of cardiovascular events when you compare it to the obstructive CAD patients. Also, INOCA has been shown to have a strong association to all-cause mortality and to the cardiovascular mortality, both gender-based and in the overall cohort. As you can see in these Kaplan-Meier curves, again comparing no coronary artery disease, minimal coronary artery disease, or the obstructive coronary artery disease. What's the economic burden of non-obstructive CAD in patients with INOCA if you compare it to the other subcohorts of 1 vessel, 2 vessel, or 3 vessel coronary artery disease? So the study on the left is primarily focusing on the Duke adjusted quality index, which, as you can see, for the non-obstructive CAD, if you compare it to the 3 vessel CAD, is definitely lower, but it's definitely higher, and the frequency is high. And if you look at the observed direct costs of the non-obstructive CAD, it has a significant implication on the healthcare system in dollars. INOCA patients have also been shown to have high anxiety levels about their cardiac status. And this study, again published in JACC Imaging 2021, compared and showed that it's almost similar to those in the hypertrophic cardiomyopathy and sudden cardiac death population. This pretty much sets the stage for the article in focus today. We have clearly shown that INOCA is a clinically important and economically important healthcare condition with significant implication on the patient's healthcare status, quality of life, and the long-term outcomes. But the relationship between the degree of atherosclerosis and ischemia in INOCA patients was not yet explored clearly and extensively. In ischemia trials, as all of you would know, multiple papers have come out. And one key thing in this trial was 21% of enrolled participants who underwent coronary CT had trial-defined non-obstructive CAD, which is less than 50%, and were therefore not randomized. And that's the analysis and the conclusions and the methodology described in this paper. So this flowchart describes the original design of the ischemia trial. There were stable patients with the major exclusion and inclusion criteria, but how was the INOCA population, which is the main focus of this paper, selected from the overall trial? It focuses on the screen failure. When these patients were screened based on the CCTA, if they had less than 50% stenosis, they were presumed to be screen failure. And smartly, the investigators used this cohort, which were actually screen failures, to create a cohort of patients for their study. So as you can see, the total enrolled in ischemia trials for this particular paper, the investigators excluded patients in which CCTA was not performed or who had prior history of CABG or prior PCI. And then they divided the cohort into no obstructive CAD and the obstructive CAD, again defined by less than 50% stenosis and greater than 50% stenosis. And then they looked at the ischemic burden for these patients, no or mild ischemia per core laboratories. Also, those patients were excluded, primarily focusing on patients with obstructive CAD and non-obstructive CAD as defined on the coronary CT with moderate or severe ischemia on different stress modalities. This was the final INOCA cohort for this paper. And then they had a comparative group. They had obstructive CAD. Stress testing was performed for clinical indications, and different modalities were included, such as nuclear MPI, stress echo, cardiac MRI, or non-imaging exercise tolerance testing. The ischemia severity was interpreted in a blinded fashion by core laboratories. And for this particular paper, only those patients who had ischemia severity assessed in the core laboratories were only included in this analysis. No patient was included where the ischemia severity was assessed in a non-core lab form. The CCDs, the cardiac scans, were assessed for segmental stenosis. And then the segment stenosis score was assessed as a measure of overall CAD plaque extent. And then the segment score was used as a measure of overall coronary artery plaque distribution. The statistical analysis was performed pretty much using any standard methodology. Patient demographics, medical history, ischemia severity by different stress modality was assessed. An additional sex-based analysis was performed. The CCTA findings of segment stenosis score was assessed, and then additional analysis was performed using the segment stenosis score. A multivariable logistic regression model was used to study the association between the demographics and the clinical characteristics. And continuous variables were modeled as cubic splines, as we will see in the result section of this paper. And if there were missing data, they used a pretty standard methodology of multiple imputations using almost 100 imputation models. What were the results? So overall ischemia cohort was 8,518. Patients who did not have CCTA were approximately around 3,200. Prior CABG around 147 patients and prior PCIs. All of these patients were excluded. And then in the rest of the patients, 688 were defined as no obstructive CAD and the rest as obstructive CAD. Among these 688, only patients who had moderate to severe ischemia, which is approximately 476 patients, were included, and this was the final INOCA cohort. For the comparator group, in a similar methodology fashion, they had a cohort of 3,136 patients. It's important to note that even in this final INOCA cohort, 27% had normal coronaries. They had no obstructive coronary artery disease on the CT scan. This is the basic demographic table of comparing the INOCA versus the obstructive CAD. What I would like to highlight here is the INOCA cohort was younger, more likely to be female, and less likely to have cardiovascular risk factors or cardiovascular disease as defined by prior MI. Also, INOCA patients referred for echo stress testing for ischemia were more likely to have INOCA diagnosis eventually, as you can see, and nuclear stress testing patients were less likely to have INOCA diagnosis. Proportion of patients with INOCA, if you see based on different stress test modality, they were higher when there was moderate rather than severe ischemia, basically denoting that a patient who had initial ischemic finding and labeled as severe ischemia, when downstream, when they were analyzed, they were more likely to belong to, they were less likely to belong to the INOCA group. This is another table showing the multivariable logistic regression of the paper. What I would like to highlight here, INOCA was associated with younger age, female sex, absence of diabetes, absence of prior MI, lower ischemia severity, and it had some association with the type of stress test modality in focus. Then they performed the gender-based analysis in a similar fashion, and the table pretty much highlights that women with INOCA versus men with INOCA were, if you focus on the woman cohort, they were older, less likely to smoke, less likely to have nuclear qualifying MPI result, and more likely to have echocardiography stress test. When they assess the correlation between the ischemia severity and the severity of the non-obstructive atherosclerosis as measured by either the segment involvement score or the segment stenosis score, they found no correlation, pretty much saying that there is no relation between the ischemia severity and the severity of the non-obstructive atherosclerosis. The segment stenosis score and the segment involvement score were significantly higher in men than in women, saying in layman terms that men were more likely to have higher proportion and significantly higher stenosis, the degree of stenosis, as you can see here, if you compare the INOCA woman and INOCA men cohort. Coming to the discussion, pretty much from this paper, some key points that we can take away are INOCA was present in approximately 13% of ischemia cohort with no coronary stenosis, with moderate to severe ischemia and fully evaluable CCTA. It's kind of suggests that there are mechanisms other than the advanced atherosclerosis that can be responsible for ischemia, even when a high degree of ischemia is present, such as severe, moderate to severe ischemia. And then the extent of ischemia tended to be less among the patients with INOCA than in patients with obstructive CAD, particularly true for participants undergoing stress nuclear imaging. No significant correlation was noted between the severity of ischemia and severity of non-obstructive atherosclerosis, as we saw in the results section. And on multivariable analysis, women were 4 times more likely to have INOCA when they were compared with men, and they were also younger. Key point here to know it, when we say the prevalence of INOCA in this study was 13%, it's likely underestimated for multiple reasons. This cohort was very pre-selected. All of these patients need to have moderate to severe ischemia. Also, these patients need to be assessed in a core laboratory format with moderate to severe ischemia. So you're already focusing on a very high risk group, which in fact maybe is less likely to have obstructive, less likely to have non-obstructive CAD. Also in the subset with nuclear MPI, the degree of ischemia impacted the prevalence. If you focus on the results, only 1.3% of those with severe ischemia had INOCA, compared with 13.1% with moderate ischemia in the nuclear MPI group. So how can you explain these findings that patients have moderate to severe ischemia, but they have non-obstructive CAD? This is the cartoon which was published in 2020, pretty much showing 3 different mechanisms of ischemia. On the left, the ischemia with the non-obstructive CAD, and on the right, the atherosclerotic disease. For the sake of the discussion for this paper, we will focus on the left side. The coronary microvascular disease and the vasospastic angina itself can lead to, can contribute to the myocardial ischemia in the coronary artery disease. So these mechanisms are frequently present and they overlap with the obstructive CAD. So coronary microvascular dysfunction may cause stress-induced ischemia in the absence of epicardial coronary obstruction. Given that the coronary artery spasm is often not identified or non-invasive testing modalities as used in this study, and that both the endothelial dysfunction and microvascular CAD may be associated with different degrees of ischemia, the prevalence of INOCA is likely an underestimate than its true prevalence in the general population as described in this study. The second point I would like to highlight is INOCA exclusively a disease of females? And the answer is no. As shown in the studies, women were 4 times more likely to have INOCA than men, and 46% of patients, but at the same time, 46% of the patients with INOCA in this analysis were male. What is the association and description of different stress test modality in INOCA? Patients with non-obstructive CAD had lower degrees of ischemia on average than the patients with obstructive CAD on CCT in the ischemia trial for every stress test modality, most notably for nuclear imaging. Maybe the nuclear imaging has a higher threshold to assess the higher degrees of ischemic burden as reflected in this study. Only 1.3% of patients with severe ischemia on stress nuclear imaging had INOCA. And then there were differences in the different modalities in the relationship between the ischemia severity and non-obstructive CAD. This pretty much can also be explained by these studies were analyzed in I think 32 countries at 170 different sites. So inter-site interpretation variability, inter-lab variability, and the inherent differences between different stress modalities, such as if you compare MPI to stress echo to non-imaging exercise stress test modalities such as treadmill, and also the true differences in the diagnostic accuracy of stress test modalities for obstructive CAD or inducible wall motion abnormality that might have led to different associations and results if you subgroup it by the stress test modality. The stress test modality also denotes a referral pattern. It has been shown that patients who are deemed to be lower risk are more likely to undergo stress echocardiography. So at the baseline, these patients were lower risk. The females, maybe they are referred more for stress echocardiography to avoid radiation exposures. These are all plausible explanations. Hypothesis generating has never been proven in a randomized exhaustive analysis. And then there is also greater variability in the interpretation of stress echocardiography in the perfusion imaging between the sites, as we were discussing. And the stress echocardiography or the exercise treadmill have greater sensitivity for microvascular ischemia than stress perfusion imaging. This is again more like a descriptive statement that requires more analysis and future studies. Coming to the point of extent of atherosclerosis and INOCA, as we saw that atherosclerosis may not be the main contributor to ischemia in these patients, and microvascular dysfunction may coexist, and all of the patients' findings cannot be explained just by the coronary plaque. In this study, multiple methods of ischemia testing were used, and the limited range of ischemia severity was based on the trial entry criteria, which was the main trial entry criteria for the ischemia trial. Also, the atherosclerosis plaque features, other than just the stenosis severity, such as the low attenuation index, positive remodeling, high-risk features such as napkin ring sign, spotty calcification, and lumen volume, may be more closely related with ischemia, but this was not assessed in the ischemia trial or in this paper per se, which is a subgroup analysis of the ischemia trial. And in addition, atherosclerosis is more common at the sites of coronary spasm, but spasm does not cause fixed stenosis. So we might be seeing spasm, which was again not assessed as part of this paper. Was the ischemia seen on stress test result true or not? Likely it was true or not, but we have few points that support that it was likely true. The core lab confirmed the ischemia without any knowledge of the patient's coronary artery disease status. So that takes away the bias of patients being falsely labeled as positive ischemia. Similarly, on other studies such as CORE MICA and WHITE study, similar findings have been shown. I would like to highlight the CORE 320 study, which showed that 27% of those referred for invasive coronary angiography had ischemia on CT perfusion or SPECT testing, but their invasive coronary angiography results were normal. So there is previous data, again supporting the findings as seen in this study. The future direction as laid out by the authors of this paper, they clearly highlight the gaps in knowledge about INOCA diagnosis and the controversy and the challenges focusing on the INOCA diagnosis and then the management. The diagnostic accuracy of the various non-invasive modalities is kind of unknown with the reference standards of invasive coronary reactivity testing or the PET imaging. And in future, we need to define the relationship of non-invasive test findings with future risk for these patients for the cardiovascular event which was not assessed in this paper. And then the million-dollar question is, once you have made the right diagnosis, how to treat these patients for the improvement and what to do with their lifestyle measures so that you see a significant improvement in their symptoms and reduce the risk of cardiovascular events, among others. Few limitations that the authors have highlighted, and I've also included on my end. CCTA was not performed on in all of the enrolled patients in the ischemia trial. The quality of life was not assessed as part of this subgroup analysis or in the ischemia trial. We have no information how these diagnoses and how these subgroups have an association with the clinical events during the future follow-up. Coronary flow reserve details were not available. CKD was primarily excluded because there was a parallel ischemia CKD trial going on. The artifacts on the CT testing might have led to false positive results, leading to negative results and more non-obstructive CAD eventually. And artifacts on the stress testing might have led to false positive results, especially for females. I would like to highlight breast attenuation artifacts and the lead placement problems when they are performing the exercise treadmill test. The lack of FFR, CCTA data, and we have no details regarding the investigative mechanisms of INOCA, primarily focusing on the spasm and the microvasculature. The real-world application, as we were discussing, the CT calcification might have led to initial overestimation of stenosis severity, and eventually they might have been included in the obstructive CAD group. Other determinants of myocardial ischemia, such as valvular heart disease, LVOT obstruction, LVH, and diastolic dysfunction were not recorded, and only core laboratory determination of ischemia limits its applicability to the real-world scenario. And unlike ischemia trial, 50% stenosis threshold was used to define INOCA in patients undergoing non-imaging stress testing. In the main clinical trial, the cohort which was defined to have ischemia on the treadmill exercise test, they had a higher threshold of stenosis at 70%. But for the sake of analysis for this paper, the authors made a uniform 50% stenosis cutoff, and then they did the subgroup analysis. So in conclusion, among patients with moderate or severe ischemia determined by core laboratory evaluation who were enrolled but not randomized in ischemia, the prevalence of INOCA was approximately 13%. INOCA was more common among women, younger patients, and patients with relatively less severe ischemia. But there was no relationship between extent of non-obstructive atherosclerosis and severity of ischemia in patients with INOCA. Thank you.
Thank you so much, Dr. Agrawal. That was absolutely fantastic. And you know, I remember when I started practice and would refer patients with an abnormal MPI, refer them to angiography, and then they wouldn't, and on their invasive angiograms, they wouldn't have a fixable coronary stenosis. We were very quick to call that nuclear test or echo test a false positive. And I think one of the strengths and the beauty of this particular analysis is that it provides for the first time high quality evidence on systematically enrolled patients where you have core lab evaluation for both their anatomic and functional evaluation, as I said, in a systematic way. And we're able to understand the patterns and the association between gender, extent of coronary disease anatomically, extent of ischemia by different modalities. So I think if anything, there will be a lot more coming on in this space of INOCA. What do you think?
As you highlighted, it is a very knee-jerk reflex to call these patients and call the ischemia test, the non-invasive modality under study, as a false positive, and tell the patient that everything is okay. but at the same time, patients are coming to us with symptoms, and there is a piece that needs to be the piece needs to fit part of the puzzle, and the part of the puzzle here is and the key takeaway for me for the from this paper is, or from the ischemia trial is, if you have a patient who is symptomatic and they have ischemia, and you do their anatomical assessment using non-invasive CCTA or with a cath, even if it is normal, that does not mean that they do not have coronary artery disease or that requires further investigation and management, and giving the false message that probably a lot of us, including me, have given to the patients over the past several years. This paper really helped me change the thought process for the patient standpoint. So I think it's a very big win for the patient care overall.
It is very well described, and there is a mounting body of evidence denoting and describing very well, actually, the change in the epidemiology of coronary artery disease. So those who practiced or who read the literature from the late 90s and early 2000s, there was high prevalence of obstructive coronary artery disease. The yield of non-invasive testing was high at that point. The rates of positivity were north of 30–40%, whereas now they are less than 10%, according to multiple studies. So that is one era. Now there is an increase in cardiometabolic risk factors, whether be it obesity, diabetes, prediabetes, CKD, and all of these are associated with a different angiographic phenotype of coronary artery disease, which is diffuse disease rather than focal severe disease, high extent or high degree of microvascular dysfunction. And it seems to me that we are still applying or looking through the spectacles of the early 2000s and late 1990s, where we're defining positivity and negativity of the angiogram based on the presence of focal severe coronary stenosis. And there are multiple studies out of Olmsted County and out of Denmark that show over time, in both men and women, the prevalence of non-obstructive coronary disease has gone up over time. This is if you take all comers to the cath lab, whether they had previous tests, non-invasive tests or not, the prevalence of non-obstructive disease is on the rise. With that said, don't you think we have to we lump two phenotypes together when we anytime we talk about INOCA and MINOCA? We include patients with normal coronary arteries, completely normal, and those with less than, depending on the threshold that you use, less than 50%. But aren't these two completely different patient populations? If you have coronary disease, you have coronary disease. But if your arteries are completely normal, you do not have atherosclerosis. How do you put this together?
Absolutely. I couldn't have said it better. If I tried explaining my reasoning, I would be just repeating the words you just said. Honestly speaking, I think combining the different phenotypes would be mixing like apples with oranges. So they are very different phenotypes. They require use of functional testing, using stress test modalities, along with the anatomical assessment. I think they need to go in parallel, and they have a equally important role in different phenotypes on how you apply. But if you try to combine all phenotypes in one basket, as I said, it's like mixing apples with oranges, and the downstream implications for this practice is on the management of these patients, because once you say that you do not have your coronaries are okay, because you just have you have no disease, but the ischemia, there was positive ischemia test. As soon as you say that, you just lost a chance to investigate it further and change the management for the patient that could have potentially benefited these patients and avoided all those downstream impacts on their mortality, major adverse cardiovascular events, and overall the economic burden on the healthcare system itself. Absolutely.
Excellent, excellent. I have a couple of more remarks and questions for you, but I would like to encourage the audience to submit their questions in the chat box, and we will do our level best to address them and answer them. One other thing that really stood out to me was the difference in INOCA prevalence by stress modality, and even within each modality there was difference according to the extent of ischemia. So as you pointed out very elegantly, it's about 1% of patients, the prevalence of INOCA was 1% in patients with severe ischemia on MPI, but it was several-fold higher in patients who have severe ischemia by exercise treadmill or with echo or others. You know, in my mind, this could be a function. This could be actually a strength of nuclear imaging, in the sense that when it is positive, it identifies, especially severely so. We're not talking about mild ischemia. These patients wouldn't make it into a ischemia trial anyways. If it's severe ischemia, these patients turned out to have severe obstructive coronary artery disease rather than INOCA in this case. But so I'm still trying to figure out why would INOCA be more prevalent in patients with severe ischemia by echo, though, which on the ischemic cascade tends to happen, systolic dysfunction tend to happen later and to correlate with greater degrees of ischemia. I tried to think about and conceptualize it, but I couldn't. I wonder if you had any thoughts about this.
Yeah, one specific comment I had, and which also caught my eye, and I think there's going to be more research and papers coming out on this, is the diagnostic accuracy of various stress test modality. Even for the obstructive CAD, there are differences in that. And then the inducible wall motion abnormality, which is the core assessment when we do the stress echocardiography, might align with a particular severity of the perfusion defect. So perfusion defect will be seen obviously on the, as you can see on the MPI, but inducible wall motion abnormalities might be aligning very differently with the different severity of the perfusion defect. And that itself maybe can partly explain stress echocardiography. Maybe the patients who are, as we saw, patients less likely to have cardiovascular disease, risk burdens, underwent more, they had more INOCA, and then the echocardiography has been documented to have a very higher specificity but lower sensitivity than the stress nuclear imaging. So maybe lower risk patients such as these, which are potentially are INOCA patients, were sent more frequently for stress echocardiography. Otherwise, yeah, those were a few points that I could think of. Also, as we know that the another thing is the patients being sent for nuclear stress test. For example, although not included in this study, I'm focusing on the lower eGFR patients. The lower eGFR patients are also associated with increased risk of CAD. So the prevalence of INOCA in this study, particularly with moderate to severe ischemia, there is a bias, and I think we might be missing out on patients who are actually INOCA and might have not been included in this study.
I think to build up on the last point, there are multiple selection biases that happen. So you started off with 8,000 patients, about 3,000 of them, we couldn't do a CT angiogram for whatever reason, renal function, prior CABG, prior PCI. So those were excluded. Those with chronic kidney disease, as you elegantly alluded, it could be a population where INOCA might be more prevalent, but we excluded those. And then you have those, you created a threshold at 50%. And I also struggled with understanding why was the 50%. I understand on CTA why 50% is a reasonable threshold to choose, but you know, we all have seen cases where you know, stenosis severity between 40 and 70% is more in a gray zone. So to me, the 50 is an arbitrary threshold. So that could potentially be another bias. But to me, it is contrary to our practice. When you see a very positive exercise echocardiogram, they tended to have severe epicardial disease, but we've seen more "quote unquote" false positive or non-obstructive disease with abnormal nuke, but not with echo. So I still couldn't explain this. There's a question, Manu, from one of the audience. Can you walk us, or we can in patients who have ischemia and no obstructive disease, what is the underlying pathophysiologies, and how do you go about working up these patients? So send the patient to non-invasive testing. It is positive cath. They have either normal coronaries or minor disease. What do you do next to tease out the underlying mechanism in this particular patient?
Absolutely, yes. So as we were discussing that, that's an excellent question actually, because it translates into the clinical practice on what to do for these patients when you are stuck with the conclusion of this paper that, okay, you have ischemia, the coronary artery disease, you get the anatomical assessment. So I think the key to highlight here is there are different facets that need to come together to explain a patient's clinical presentation. And I believe most of them we don't even know. But some of them that we know about is one is the coronary microvascular dysfunction. So the assessment, further assessment of coronary flow reserve using the PET MPI scans, which can give you the global flow reserve and the CFRs. They have a lot of literature. So getting an assessment for that will help to further stratify and get to the root of the problem. The second thing will be looking for vasospasm. So you can perform tests for these patients in your cath lab with the protocol that we basically challenging them with agents such as acetylcholine and looking for the vasospasm. A lot of times we have sent patients to the cath lab where their coronaries look like they have disease, but as soon as you push nitroglycerin, they open up wide, proving that the vasospasm itself is a very, very important player for this study. So I think additional testing definitely deserves attention using PET MPI, cath lab, not focusing just on the anatomical assessment, but on the functional studies to define the underlying pathophysiology that can help these patients and their management.
So is it safe to summarize and say, and do you agree that, let's say a patient has a SPECT as a qualifying test, and they either have ischemia or no ischemia, and then they go on and continue to have symptoms, unexplained symptoms, Your next step would be non-invasive testing or invasive testing. I think the next step might be to get a comprehensive non-invasive evaluation of the entire coronary circuit prior to sending them to invasive angiography. And the available modality for that would be cardiac PET, where you evaluate for epicardial coronary disease. And you also get an opportunity to evaluate for coronary atherosclerosis. So you get testing for ischemia. Then you evaluate coronary function, and you are able to assess in each territory and at the global level, you get to assess the myocardial blood flow reserve, as you said. And if you still do not have an answer or an explanation for the patient's symptoms, I would send the patient to invasive assessment because what we haven't assessed in that paradigm that you described is coronary vasospasm, where you challenge them with acetylcholine. Let's take one more question before we return to our case and wrap up. Back to the gender issue. As you pointed out, INOCA is not a disease of women. Almost half of the patients were men. But compared to those with obstructive disease, patients with non-obstructive disease were 4 times more likely to be women. Is this biology or different angiographic phenotype that's more common in women?
Yes, so I think there has to be some mechanism at the gender biology that might have an association with this INOCA. But one thing I would like to highlight is the patient characteristic itself. If you look in the INOCA population, all the literatures, all the papers, the most extensively studied patient characteristic is gender. So a substantial proportion of the INOCA conversation had been focused on women, and they have lower likelihood of obstructive CAD when they're presenting for signs and symptoms with ischemic heart disease. And this has been, the similar finding was observed in the main ischemia population, where 15.1%, approximately 15% of the women with nuclear MPI evaluation had INOCA compared with only 5%, I think 6% of the men. Also, despite the lower prevalence of CAD, women have higher rate of cardiovascular events. And this risk is, the study has described then that this highest rate of cardiovascular event is focused in those patients which have reduced coronary flow reserve, like CFR. So it is very critical to identify these patients with impaired CFR with additional testing, to highlight on the first point. And the third thing I would like to highlight is higher rate of men undergo ischemia evaluation. So when the denominator is so high, the actual makeup of the INOCA population actually becomes similar across the genders. So yes, there is in this study, and there is pre-existing literature that the gender has an association, like female gender has an association of more likely to have INOCA, but then the actual makeup of the INOCA population is similar across the genders. But yeah, so that's how I conceptualize about the gender differences in this patient population.
Fair enough. We have about 10 minutes left. Okay, so if there are no other questions, I'm just gonna go ahead and let's get back to our case. Let's see if we can move. So remember, this is a 70-year-old female. This is the summary. 70-year-old female, recurrent chest pain for the last 3 years. Had an invasive coronary angiogram that showed non-obstructive coronary disease, had a normal SPECT, and had minimal response to nitro spray. So it kind of alleviated some of her symptoms, but never improved them completely. And as we said, before subjecting the patient to another invasive procedure, we thought that let's get an opportunity to complete our non-invasive evaluation. And the patient was indeed referred for a vasodilator PET MPI. And as you see, the rows are short axis, then long axis in the bottom 4 rows. Stress is up top, and then stress, rest, stress, rest. And as you can see, there was no evidence for ischemia, and this is the evaluation for obstructive epicardial disease, which we know the patient didn't have, but you get further confirmation. The patient also had a normal global myocardial blood flow reserve, and this is one of the major advantages and strengths of vasodilator PET MPI, whether it's done with rubidium or with ammonia, as your ability to assess quantitative blood flow, and by being able to do that at rest and at peak stress, you are able to assess coronary flow capacity or coronary flow reserve. And for this particular patient, it was normal at 2.3. So we know that the patient has no epicardial disease. We know the patient had normal or preserved myocardial blood flow vasomotor function. We know that the patient continues to have symptoms, and the answer, we still need an answer. So the patient was taken to the cath lab for an invasive assessment of coronary vasoreactivity and a challenge. So this is the patient's coronary angiogram at the beginning. They performed intravascular assessment of for microvascular function, which was again normal and corroborated the findings from PET. The patient had acetylcholine challenge. As you can see, there was severe vasospasm. If you compare the middle segment of this vessel to this vessel, that completely resolved after reversal. And as you can see, this patient was diagnosed with coronary vasospasm and was treated with calcium channel blocker with a good improvement and good response in terms of symptoms. So any comments, Manu, before we close?
One question that always comes to my mind is when I see such patients is I'm sending them for the testing. Should I just stop their treatment completely? Because in my mind, we might be underestimating their diagnosis, despite no improvement in the symptoms. Any comments or thoughts about it?
Yeah, so it is a routine and customary. You know, you're putting them through an invasive test. It's routine and customary that these medications are withheld 48 hours before. Your point is you want to get a best estimate, you know, of the indices, the invasive indices for coronary vascular function, and you do not want to send them a test and set them up for a false positive. I'm sorry, a false negative in this case. So yes, we would stop nitrates, beta blockers, and calcium channel blockers before they are referred to invasive assessment in order to maximize the diagnostic yield of the test.
Absolutely, and as you depicted in this patient, it's not just putting them on a calcium channel blocker or a beta blocker. It's finding the root of the problem and the diagnosis, because the patient is there with symptoms and they want to know what's going on with them. And just saying, yes, we have ruled this out, but we don't know what's going on, it just creates anxiety at the patient level and impacts their quality of life in a very significant manner.
So I don't see any additional questions. I would like to thank you for your deep dive analysis of this article. I know it can at times become difficult and tricky with all the the different terminologies and the different explanation. But I think you've done an outstanding job dissecting this article. And I personally find this a very fascinating and exciting area, and I anticipate that our understanding and knowledge is only going to increase in years to come. And because these patients kind of want to make a pitch online, and because such patients are not, are still encountered, but not as frequently encountered as the mainstream or commonplace obstructive disease. I think one way to advance our knowledge and understanding is to collaborate across sites, across countries in the region, to share knowledge, share expertise, and share cases, and generate some science that we can hopefully add to this exciting and growing space, and hopefully bridge some of the existing gaps. So this is a pitch online to inter-site, cross-country collaboration to collect data, to create multi-site registries to help advance our knowledge. And with that, I would like to thank again Dr. Manu Agarwal from Cleveland Clinic. I would like to thank Emirates Cardiac Society for this opportunity. I would like to thank the participants and the audience for their time, and stay tuned for additional imaging working group activities in the coming months. And with that, I conclude, and I thank you for your attention.
Thank you so much.